Well, hello everybody. Good morning, good afternoon, good evening, depending where in the world you're viewing this from. My name is Neil Bettridge. I have the honour to chair the Global Remission Coalition, the GRC, and it's our pleasure today to bring you the final webinar in our series for 2025. But please be assured we will continue to provide these webinars in 2026 and beyond. The coalition was actually only launched in May of this year at a meeting alongside the World Health Assembly, where we had 35 member organisations at the time. And since that time, in those few months, that membership has more than doubled. So I think that indicates the degree of passion and interest that our stakeholders here have in the topic of supporting patients to better and more often be able to pursue and hopefully achieve remission. And today we're very much going to be focusing on that aspect of people with lived experience of chronic inflammatory conditions speaking for themselves directly about what it means and what difference it can make, either to be well supported, to pursue and maybe achieve remission or not. And that difference, as many of us know, can be huge. So we have two expert patients, but today Ailsa and Cheryl are really going to be majoring on being the patients. This is about direct experience more than representing the organisation. But for transparency, as you can see from the agenda, Ailsa is the founder and the national patient champion for National Rheumatoid Arthritis Society, NRAS, in the UK. And equally, we welcome Cheryl Zubrak from Dragon Claw, which has a base in Australia, a lot of active membership in Canada and other countries too, so is international in scope. And after hearing from Ailsa and Cheryl, it's our pleasure to have with us Katie Swaninen from Finland to get a rheumatologist, a clinician perspective on the issues that Ailsa and Cheryl have raised. And we'll try and get through in 30 minutes. So with no further ado, Ailsa, I'll pass to you, please.
Thank you very much, Neil. Hi, everybody, and thanks for the opportunity to share some experiences with you today. So I've lived with seronegative RA for about 46 years. I'm not your classic RA presentation, but a bit of a mix of things, really. I'm negative for rheumatoid factor, negative for anti-CCP antibodies, and I have the HLA-B27 gene, which is normally associated with ankylosing spondylitis, as my father had AS. I've also lost the useful sight in my right eye to uveitis, which my father also had. I don't think I've ever achieved what I would consider as remission, i.e. a sustained period of time with no discernible symptoms. I firmly believe that the reason for this is that I was diagnosed such a long time ago when the disease was treated very differently, and we certainly didn't have the advanced therapies that we have today. So what has happened to me is the reality of what happens in RA and other immune-mediated inflammatory conditions when you don't diagnose early and treat effectively. I had symptoms for about a year in my right knee before I was forced to go and see the GP by my boss at the time. Although my father had severe AS from before I was born, I didn't associate what was happening to me with anything to do with my father. And I suppose that was because at the time our parents didn't really discuss any of the detail of what was going on with my dad, with my brother and I. So we didn't really understand the nature and the detail of what his disease was. By the time I was in front of the GP, my knee was so swollen and painful that the diagnosis was very quick. And within days, I found myself in hospital, having my knee drained of fluid and injected with steroid. And then I was put in plaster from my ankle to the top of my thigh and on bed rest for a week. And that was the start of my long and difficult journey, which continues today. I spent the first 3 years of experiencing severe and aggressive disease, during which time I had the first of 21 surgeries, but I was only being given painkillers and anti-inflammatory medication. During that time, I also had my daughter. My disease did actually go into remission whilst I was pregnant, as can happen with some women, but within weeks of giving birth, it returned with a vengeance throughout the rest of my body. And I had my first knee surgery, a synovectomy, when Anna was only 9 months old. My consultant was not a very nice individual, and I can recall frequently leaving her clinic in tears and going home feeling confused and bewildered about what was happening to me and feeling very alone and isolated. We didn't have multidisciplinary teams back then, and it was only when a relation who was a doctor living in Holland came over one Christmas, saw how ill I was and how much weight I'd lost, and found another consultant in London for me to be referred to. So I got my care transferred to the new doctor, and he really started to try and get my disease under control for the first time. However, I'm one of the 5 to 20% of people with rheumatoid arthritis who experience refractory or difficult to treat RA, meaning that my disease doesn't respond adequately to multiple conventional treatments and often to many of the biologics or targeted synthetic DMARDs. And for the first 20 years of my disease, the only treatment that had some impact on symptom control was steroids. I was on a dose of between 5 and 7 milligrams of oral steroid per day. And for that period of time, as none of the standard treatments worked for me. This is not something that would happen today, as we now know that even a relatively low dose of steroids for any length of time can be damaging. And of course, we have a much wider range of effective treatments today. Then in 1999-2000 came the revolution in rheumatology, which was the advent of the biologics and the first TNFs. I was on a clinical trial in 2000 of an anti-TNF, and for the first time since being diagnosed, I found a treatment that made a real difference. That experience and being told at the end of the trial that I wouldn't be able to get the drug because it was very expensive and no one would fund it, led directly to me starting NRAS. It took me 6 months of fighting to get myself back on treatment. However, since that time, I've had 9 switches of advanced therapies, including biologics and the targeted synthetic drugs, the JAK inhibitors, and considerably more surgery. I've had multiple operations to both feet and ankles, with both ankles being replaced and one twice. Both knees are replaced, both hips, both elbows, both wrists are fused, and my neck is partially fused, plus 4 operations on my eyes. So when not adequately treated, this disease is incredibly destructive. I've learned so much since starting NRAS, and I'm still learning. But my experience is an example of why RA and other immune-mediated inflammatory diseases must be treated as medical emergencies, and why addressing symptoms early and getting diagnosed and started on treatment as soon as possible gives you a much better chance of getting your disease quickly under control and getting it into remission, something I don't think I will ever achieve because too much damage has been caused. But I do think that we have to be realistic in the coalition that some people are not going to be able to achieve remission. But as long as we can target as low a disease activity state as possible, then that may be the option for some people. So I'm going to stop there and hand back to you, Neil. Thank you.
Thank you, Elsa. Thank you so much for sharing that. It's really powerful. I know I know you, so I know what you've been through, but it's still always incredibly powerful. But also very empowering to hear what you're saying. And you're right, we do need to be realistic. We regularly say at the coalition that remission isn't going to be possible for every patient, but should be the goal for all. And then it's about seeing how far you can go, which is why we use this phrase, the pursuit of remission. Right, let's get everybody to the best place they can be. So thank you. I should have said just before you spoke that in terms of questions and answers today, please, everybody watching this, please use the Q&A to put your question in. And then after Cheryl has concluded, we'll take a look at those questions, and Catty and I will discuss what we've heard, and maybe Elsa and Cheryl, if you want to come back with comments then also. Thank you, Elsa. I'll pass now to Cheryl, please.
Hello, everyone. Thank you for inviting me to share my story. My name is Cheryl Zubrak. I have rheumatoid arthritis, and I am most gratefully in remission. To give you some context, I'm going to start with life before RA. I was healthy. I didn't have any issues. I was carefree. I had endless energy. When I got a new family doctor in 2019, I told her she would hardly ever see me. Little did I know. It was during COVID. and it was October of 21 when things went awry. For whatever reason, the annual flu shot I received triggered a severe flare. I realized afterwards that something had been simmering in the background for several months. But I had a lot on my plate, and as we tend to do, we just keep going, not listening to our bodies. That initial flare extremely compromised my mobility. I was sick and utterly bewildered, not to mention terrified. Thankfully, after a few family doctor's visits trying to figure out what was going on, I was able to see a wonderful young rheumatologist in short order. Thankfully, my CRP numbers were high enough that it was an easy diagnosis, so I'm a positive, and there was no questioning. Thankfully, my daughter had a connection to Charmaine at Dragonclaw and suggested I contact her, which I did, one of my best decisions. And thankfully, we have a healthcare system here in Canada that is able to fully support my medical journey. In our province of Manitoba, which is in the center of Canada, and I'm sure it's the same in other jurisdictions, we go up a ladder of medications, least costly to far more expensive. I went through the usual regime of pills, injections, and various biologic IVs. And I am needle phobic, so this was traumatizing for us. At the end of December of 22, I was prescribed a JAK inhibitor, a pill. I was so grateful. I knew within the first month that something was different, something was working. For the first time, I sensed a change. Nevertheless, it took 5 more months to get off prednisone. I also decided to stop my methotrexate injections, which for me was the right decision. And I made that decision on my own, but I felt better afterwards. In total, it was about a 2-year journey, short in so many ways, but it felt forever while I was in the thick of things. So what I've learned about remission is that it's important to understand that remission doesn't mean we are cured or even completely symptom-free. Remission may be temporary or permanent. For me, remission means my RA is on hold. The wonderful part of being in remission right now is that I have most of my life back. Every morning at 8:30 a.m., my phone bings and I say a quiet thank you and I take my magic pill. I'm able to go for long walks, cycle, kayak. I do a lot of yoga, which is hugely important for me because I stiffen up quite easily. And my latest activity, Golden Zumba. It's so uplifting. It's winter here in Canada, and the river behind our home is frozen, so I'm in full shovel queen mode, helping clear the skating trails. And I think I get that title because I'm the oldest one out there. So you can see that movement is hugely important. Motion is lotion, and there's a lot of truth in that little saying. One of the highlights of achieving remission was I was feeling well enough to be able to hold my first solo art exhibit in March of 22. I'm mentioning this because through this particular experience, I realized that RA was actually enriching my work. My practice involves a lot of physical activity. While my mobility was compromised, I had to be creative and find new directions in my work. I often have referred to RA as my oddly wrapped gift, my creative journey with RA being one of these gifts. My JAK inhibitor meds are my force shield. They're working hard to keep my RA symptoms at bay, ideally far, far away. But my shield can also be a little sensitive. It will weaken and get overwhelmed, and then I'm reminded that it is not 100% impermeable. I'm often aware that RA symptoms quietly lurk in the background. When I get overtired, don't sleep well, or especially when I'm emotionally stressed, RA sends me a reminder that I'm definitely not alone. Some of the symptoms that will sneak through my force shield are stiff and achy joints, a creepy crawly skin sensation that began at the beginning of my RA journey, and waves of fatigue. I often feel I'm on the edge of getting sick. Sometimes I find social situations, especially one-on-one conversations, draining. I know when I've hit the wall. But life goes on. So many people deal with so much more, as we have just heard, that I can't wallow in even a millisecond of negativity or self-pity. I'm so very fortunate. I'm deeply grateful for the progress that has been made in the field of rheumatology and the various pharmaceutical treatments for RA. It is truly amazing. It wasn't all that long ago that people diagnosed with RA had to endure a lifetime of suffering with minimal treatment options available. I count my lucky stars that my body waited till 2021 to get RA. I'm also deeply grateful for organizations such as Dragon Claw, and especially their weekly Dragon Talks. Knowledge is power. Dragon Talks is my support system and my information station. I've learned so much, and I've benefited from being a part of a caring community that understands but doesn't let anyone whine too long. I am indeed extremely fortunate to be in such good hands in so many directions. So cheers. Here's to remission. May it last. Thank you.
Thank you, Cheryl. Thank you so much. Again, really, really powerful. And, we've heard two amazing testimonies here from people living with RA, rheumatoid arthritis, people with axSpA, people with non-rheumatological chronic inflammatory conditions like psoriasis or irritable bowel disease. I'm sure that will resonate what you've talked about there, because you're really highlighting, aren't you, the sort of the need for change when this kind of disease hits, whether that's environmental, psychological, emotional. And I loved your phrase about the oddly wrapped gift. I'm sure many of us with that kind of experience can relate to that, because, for all the negatives, it gives you insights that might be denied otherwise, right? So thank you. Thank you very much. Wow, Catty, I'd like to turn to you now, if I may, please. Thank you for joining us. I don't know where to start after those powerful testimonies. I've got a couple of specific questions I see coming into the Q&A, and a couple of things I'd like to ask you directly, but is there any overall response you want to make to anything you've heard so far before we get into those?
Hello, everybody, and thank you. I'm very touched. Those two stories. Something similar I hear here in Finland also, not every day, but often. And I'm very happy to be here, and feel honored to be here and listen to your stories. And I can only agree.
Right.
Both.
Yeah. So looking at the questions then and the issues raised also, I'm just wondering, Catty, when a patient and a clinician agree that that specific patient has reached remission, is there a consensus amongst clinicians about what should happen next? Some people might be wondering, for example, does that mean on the pharmacological side of things that we've hit the right place and treatment should be maintained exactly as it is because it's working? Or do you think there's other opinions about whether treatment should be reduced or tapered in some way to see whether remission can be maintained in that way? What's the prevailing view amongst the clinical community, if you have an opinion on that?
Thank you. That's a good question. And I think it's always has to be thought on an individual basis. And tapering, there's always a risk of losing this remission. But also our medications are not 100% safe. So if we have over medication, it's also not good. So I at least always talk with the patient, and the severe the disease has been, the more careful I would be in tapering. And it also depends on this disease. Some are milder, and we know that they even might that people even might achieve drug-free remission. And I think what we first do nowadays, as Eliza already mentioned, we try to taper and stop corticosteroids, because that's something we know that in the long run they cause problems. Also in low doses, not necessary, but there is a risk of that. So tapering corticosteroids, I think it's very common in the clinical practice. But then other drugs, these DMARDs and biologicals, they are more careful. So it's possible, but you must be careful. And especially in TNF blockers, there is the risk of immunization. If you taper or stop, it might be that you lose the effect of that particular medication. So there is I think there is no consensus what to do, and it's always something you need to consider and talk with your patient. So.
Sure, thank you for that. And thinking about what is involved in the process of pursuing and hopefully achieving remission, from a clinical point of view, do you think that's mostly about finding the most effective treatment, or are there things which the patient themselves can also be doing that would improve their chances of achieving remission? Apart from adhering to the therapy, of course, which we know often delivers the best outcomes.
Thank you. That's also a good question. As we hear in both of our testimonies, the effective medication is very important, and that's something we didn't have back to the 80s or even 90s. But it's not the only thing, and it's also individual. In some patients, we see that they can do a lot. Some people can do less because the disease is so severe. But what I always say, as Cyril already said, motion. So sports, motion, whatever you do, walk, go to swim, yoga, it's very important to move. And there are even some scientific evidence that the people who can do sports, they have a bit lower disease activity. So it's always something we can recommend. And of course, it gives you better you feel better as also mentally if you are able to move. And then of course, if you tobacco, cigarette smoking and nicotine is very bad. So that's something those people who smoke they can stop. But of course, I think at least here in Finland, most of the people do not smoke and they still get rheumatic diseases. But that's something you should avoid. And one more thing, of course, is the weight. So normal weight is recommended because obesity, it can worsen your disease. And of course, it's also a mechanical stress to your joints. But underweight isn't good either.
Got it. Okay, thank you. And question from Charmaine. Hi, Charmaine. About, I think this refers to our previous question, Kati.
Yep.
Charmaine's asking, when a trial involves, or when there's a period of reducing or stopping TNF, why is it not effective if and when it is restarted? I guess for some patients it might be, some not. I don't know. And a more general question: is this a risk involved with stopping any such therapy? I guess any biologic in particular.
So this it's not always the case. But there are some of the TNF blockers, especially infliximab and adalimumab. There is the possibility that your body begins to build antibodies against this medication, and then you lose the effect. And it can happen anyways, but the risk is higher if you stop or taper. It's less in other TNF blockers like golimumab and etanercept or certolizumab. So there is the risk is definitely lower. The antibodies you get there are mostly not that bad, that serious. And in other groups, there is little or not at all the risk of getting immunized. So you basically lose the effect of the medication. But in other groups like JAK inhibitors or rituximab, you don't have the same effect. But sometimes we also see that even there's some other some other mechanism in the background, that if you stop the medication and start it again when the flare comes, it does not necessarily work as well as it worked before. It's maybe the same effect as we already heard, that you should really act fast. So if you have a new rheumatic disease, I think also that is a medical emergency. So here, if I see a referral with swollen joints, I want to see the patient at the latest in 2 weeks. So we really need to act fast. So I think the same thing is in the flares. So if the disease already gets worse, so then there's a higher possibility that you can't get it under control with the same medications as before. I don't know if I answered the question.
Yeah, no, you did, I think. That's very clear. Thank you. Thank you. We've got just a couple of minutes left. Ailsa, I'm going to call you in because I see your hand is raised. There's also a question in the Q&A from Mariana. Hello, Mariana. Asking about access to treatments and biologics in particular in the first world or global north, I guess, in modern parlance. I know that's a huge question, but are you very, very succinctly able to say whatever you wanted to say anyway, and also briefly address Mariana's question about access in the UK, just as an example?
Are you asking me or Catty?
Yes, Ailsa, sorry.
Oh, sorry.
No, Ailsa, sorry. So you had your hand up, I think, Ailsa.
Yes,
and
I
also
did.
Mariana was asking in the Q&A about access in a country such as the UK.
Okay, yeah, I'll briefly on that. Yes, we have NICE in the UK, the National Institute for Health and Care Excellence, who sign off on the new drugs coming into the UK. We do have a bit of a mixed situation going on in that in some parts of the UK, in Scotland, for example, there isn't really as much restriction as there is in England. We do have some commissioners where they are restricting use of a biologic up to maybe 3 or 4 different types of biologic, and then they say that's where you have to stop, which we believe is fundamentally wrong, because there is evidence that even in someone like me who's had 9 switches, I still come back to one drug that is actually holding my disease in reasonable control. But yeah, there's no doubt that the biosimilars have changed a lot in terms of access, and now everybody who goes onto a biologic goes on to the one of the biosimilars rather than an originator, which actually I'm still on. I don't know whether that's answered the question, but
yeah.
I think I just quickly wanted to touch on, Neil, was in terms of what patients can do themselves, which we were talking about before. We've just finished filming 3 new modules for our Smiley Learning program on managing cardiovascular risk. So managing risk of comorbidities, I think, is very important. And that's something that we can do something about. We can make sure we get our blood pressure checked. We make sure we get our cholesterol levels checked, and things that where we do need some medical help and support with, but I totally agree with what Catty said about the smoking and the weight control and exercise.
Sure. Thank you. Thank you, Ailsa. Thank you. Gosh, time flies on these webinars. We have to wrap up shortly. Cheryl, is there any 1 sentence or 2 sentences that you wanted to come back with? While you're talking, we'll actually show the next slide, which helps people find the GRC resources if they want to. But I just wondered, Cheryl, if there's anything you wanted to round off on very briefly.
No, just I'm so grateful to be here, and thank you very much for the opportunity. And I have to agree, looking after yourself is critical, and staying in touch with your doctors. And just, if you look at Dragon Claw's page, there's the 5 pillars of health, and just, being good to yourself, stay moving, eat good food or healthy food, and stay in touch, learn as much as you can. My goodness, aren't we fortunate that we can all be in touch here? and you're not isolated like we would have been 30 years ago without all of these technologies. So thank you very much.
Absolutely, thank you. Yeah, it's a great note to finish on, I think. I mean, self-management alongside appropriate pharmacological support is so important, but supported self-management is really important, isn't it? And we have a right to expect that from the healthcare system. It's not something we should have to feel grateful for. And specialist nurses and patient groups are so important, aren't they, in providing that additionality to the great work that our clinicians provide. So, thank you, Elsa, Cheryl, and Catty for volunteering your time for this webinar. I'm sure people who have seen it already will find it valuable. It will become a podcast on the GRC website soon after. As I said at the beginning, we'll be continuing these webinar series throughout next year as part of a wide range of activities that the Global Remission Coalition will continue to undertake. We can only do it with the support of our members and other stakeholders. So our thanks are enormous to those people. To the members, we'll see you next Monday at the final coalition meeting of the year, I hope. And to everybody else, happy holidays if you're going to be celebrating in a few weeks. Thank you for joining today, and let's see what we can achieve together in 2026 and beyond, because this stuff matters. Thank you, everybody, and goodbye.
Bye.